Hello everyone! Welcome to Marsden Advisors Information Blocking Overview webinar. We're doing this today, April 5th, in honor of the compliance date of the Information Blocking Rule. My name is Jessica Peterson and I'm the Vice President of Health Policy at Marsden Advisors. Here at Marsden Advisors, we have over 50 years of combined experience in EHRs. My personal experience in health policy related to the Information Blocking Rule has spanned basically since its inception, where I've been working alongside ONC and specialty societies in its development. As I said at the very beginning, today marks the information blocking compliance deadline. So we're going to get you off to a good start, starting with an information blocking overview, background of the rule, and definitions that we'll use throughout the presentation. Then we'll move into exceptions to the information blocking provisions, and next steps, how you can prepare. Before we get going, we need to go over some housekeeping items, specifically the legal disclaimers. This webinar is provided for general information purposes only and does not constitute legal advice. The Department of Health and Human Services, Office of the National Coordinator of Health IT, or ONC for short, established the provisions that we will review in today's webinar as a result of the 21st Century Cures Act of 2016. This was a broad and sweeping piece of bipartisan legislation that covered topics from drug discovery to substance abuse treatment to interoperability. The law required the Health and Human Services Department to promote interoperability and specifically to prohibit information blocking. ONC's information blocking definition has two parts. Part A on your screen defines the practice of information blocking. Part B defines the content that must be included in the information. Focusing on Part A, you'll see that I highlighted and underlined certain portions of the definition. These are the portions that are most relevant to providers. Beginning at the top, you'll see that information blocking is a practice that, except as required by a law or covered by an exception, is likely to interfere with access, exchange, or use of electronic health information, or EHI. Note that no actual harm or interference is required. The requirement is that the act is likely to interfere. The second highlighted statement shows the requirements for a provider for information blocking to be determined. A provider has to know that the practice is unreasonable and is likely to interfere with access, exchange, or use of EHI. I pointed this out because it's a very important difference between the definition of information blocking actions for a provider and those for an EHR or health IT vendor. For a health IT vendor, they need to be likely to know, so they know or should know that such a practice is likely to interfere with the access, exchange, of use of EHI. Whereas a healthcare provider has to know that the practice is unreasonable and likely to interfere. Looking at Part B, this is the content of information. What this is basically saying is that up until 24 months after the final rule, there is a more limited set of information that must be shared. This is called the U.S. Core Data for Interoperability Standard, or USCDI for short. After those 24 months, all EHI must be shared. The definition of information blocking relies heavily on the terms that you see on your slide: access, exchange, and use. So what do these terms mean? Well, legally, these terms mean the following: access, the ability or means necessary to make electronic health information, or EHI, available for exchange or use. Exchange, the ability for EHI to be transmitted between and among different technologies, systems, platforms, or networks. And use, the ability for EHI, once accessed or exchanged, to be understood and acted upon. In the context of information blocking, an act is information blocking if it is likely to interfere with access, exchange, or use. This means that there is a reasonably foreseeable risk, even if it doesn't materialize, that a practice will prevent, materially discourage, or otherwise inhibit access, exchange, or use of EHI. So let's take a quick look at the information blocking timeline. Today, April 5th, 2021, is the compliance deadline for the information blocking provisions contained in this rule. Starting today and continuing through October 5th, 2022, you must allow access, exchange, and use of the data elements reflected in the USCDI, which we'll go over on the next slide. On and after October 6th, 2022, the definition of EHI is expanded to include all health information contained in an electronic record. Although today is technically the compliance deadline, HHS has not yet published an enforcement rule. Because of this, they will exercise enforcement discretion in cases of information blocking. So you still have time to evaluate your practice's workflow and procedures related to information blocking and ensure that you have taken the necessary steps to comply with this rule. As promised, here are the data elements contained in the USCDI standard. Currently, clinicians using certified EHR technology, CERT for short, are able to send information to one another using the Common Clinical Dataset, or CCDS. The USCDI replaces the CCDS. Most of the data elements on this slide should be familiar to you from the CCDS, but there are additions including allergies and intolerances, specifically a field for the drug class and reaction, additional patient demographic elements, provenance, pediatric vital signs, and, most importantly, clinical notes. That's right, patients must now have access to full clinical notes, not just care summaries. While this set of data may seem overwhelming, medical groups are only required to report the data elements that they have captured. For example, it would not be considered information blocking if the patient's smoking status was not captured and, thus, not made available to the requester. In short, you can't block information that you don't have. Finally, it's important to note that the USCDI is an evolving standard. ONC established the USCDI annual update process to allow for a predictable, transparent, and collaborative process to expand the USCDI. Currently, ONC is working on version 2, which may go into effect next year. So it's important to keep up to date on what data elements are included under the information blocking rule. Now that we know what information blocking is and what information is currently required, it's time to explore what information blocking looks like. Let's start by taking a look at examples of EHR vendor information blocking practices. First up is implementing health IT in ways that are likely to restrict access, exchange, or use of EHI. This could be things like making it difficult for a clinician using the EHR to send a direct message or information contained in the USCDI dataset to a clinician that they are referring a patient to. That is an example of functionally blocking the flow of information. Next up, restrictions on access, exchange, and use. These are most often expressed in contracts, such as overly restrictive license terms or very high fees for the transition and sharing of information. Next, impeding innovation and advancements in access, exchange, or use of health IT-enabled care delivery. This could be things like refusing to license an interoperability element or not allowing third-party apps that conflict with the EHR's business practices, such as being sponsored by a competitor, to use the API or application programming interface to get data from the EHR. And finally, rent seeking and other opportunistic pricing practices. This one's pretty self-explanatory. Any over-the-top fees that are really more than recouping costs or making a reasonable profit are disallowed under information blocking when it comes to those fees being applied to the sharing of information. Now let's look at healthcare providers. The focus of this presentation really is for healthcare providers, so I want to go into a little bit more depth, which is why there are more examples. Let's start with the first bullet: internal policies or procedures that are more restrictive than state or federal law. So state and federal laws like HIPAA, which does vary state by state, are required when it comes to determining what information you can and cannot share. If your internal policies, for example, require staff to obtain an individual's written consent before sharing any of a patient's EHI with an unaffiliated provider for treatment purposes, that could be considered information blocking because individual consent is not required by either state or federal law for treatment, payment, and operations. Next up, policies that delay information release. This one is actually pretty commonly done by healthcare providers. For example, having a blanket policy that specific test results, such as HIV test results, aren't released to the patient until you have a chance to review them and speak to the patient. I know a lot of doctors do things like this so as to protect the patient's emotional health so that they can ask you questions right away, and you guys can have a discussion about what the results mean. Under the information blocking rule, however, that is information blocking. So make sure that you don't have any policies in place that routinely delay information release to patients. You can do this on a case-by-case basis, but only case-by-case. Next, the same that we looked at on the EHR vendor side, implementing health IT in ways that are likely to increase the complexity or burden of accessing, exchanging, or using EHI. It's really the same as it was under the EHR vendors. There are practices that set up their EHRs in such a way that doesn't really focus on the information sharing portion of the EHR and makes it very, very difficult for providers in that practice to send information to another provider. So make sure that when you have your for instance, annual security risk analysis, you also take a look at how you're sharing information and how you've set up your EHR in that way. Next, limiting or restricting the interoperability of health IT. So an example of this would be disabling or restricting the use of a capability that enables the sharing of EHI between users of other systems, or by restricting access to EHI of certain types of persons that are legally permissible, or refusing to register a software application that enables a patient to access their EHI, assuming there's no actual security risk to your practice. I know that was a long list, so let's look into one example in a little bit more detail. Let's say a medical group has an application programming interface. Again, that's something that allows, say, a third-party health app that you might have on your phone to access information stored within the EHR in a secure way. But they don't share the endpoint information. The endpoint is basically the address that those apps use to connect to the API. This is an example of information blocking because it makes it difficult for third-party apps to connect to the API, and it could prevent patients from getting their information in the way that they want it and in a way that allows them to be more active in their care. Next is using business associate agreements, or BAAs, to permit access to EHI by certain providers for treatment purposes, but limiting access to the same information for the same purposes by a patient's other providers. I don't see this done very often, but apparently it is a complaint that ONC has heard fairly frequently. So just make sure that you don't do that. Make sure that your practices are uniform across the board and applied consistently, and that they follow HIPAA. Finally, discouraging or preventing a patient from sending their EHI to third-party apps. We talked about this one a little bit further up under limiting or restricting health IT interoperability, but you also can't discourage a patient from using a third-party app. This is a little tricky because a lot of healthcare providers are concerned about the privacy and security standards of these third-party applications because these are not applications that are covered by HIPAA. You are allowed to tell your patients that they're not covered by HIPAA as long as you do that for every application, every time a patient requests that their data be sent to a third-party app. So if you have a policy of uniformly informing patients that the app is not covered by HIPAA, but not materially discouraging them from using it, that's fine because you're just making sure a patient is informed. However, if you go further to say, to a patient that they shouldn't use this app because it's not covered by HIPAA, that would be considered discouraging them, and it would be considered information blocking. I know these are complicated, but I hope that the examples helped. So that was a lot, and you might be wondering, what do I do when I can't provide the information? Well, ONC thought of that. There are 8 exceptions to information blocking. Since this presentation is focused on providers, we're just going to focus on 5. The preventing harm exception, the privacy exception, the security exception, the infeasibility exception, and the content and manner exception. First up is the content and manner exception. The content and manner exception states that it's not information blocking for you to limit the content of your response to a request for access, exchange, or use of EHI, or to limit the manner in which you fulfill a request to access, exchange, or use EHI, provided certain conditions are met. The 2 main conditions are the content condition and the manner condition. Starting with the content condition, this exception is pretty much what allows you to use the USCDI for the first 24 months or until October 5th, 2022. And that after October 5th, 2022, starting on October 6th, you must use the full definition of EHI. So that one's pretty quick and simple. The manner condition is for when you receive a request for EHI using a very specific manner of transmission. Let's say, for instance, another healthcare practice says that when you discharge their patients, that they would like you to automatically send that information, the patient visit information, to a specific health information exchange network, which requires a specific format. You might not be a member of that health information exchange network, so you can work with that other practice, the requesting practice, to find a way to make it work for you. For instance, you can see if they'll help subsidize the costs of subscribing to that health information exchange network, or if they're willing to somehow work around it. If you can't come to agreeable terms and you're technologically unable to fulfill the request in the specific manner requested, because say you are not set up to integrate with that exchange, then that's where the manner condition comes into play. Another example of when the manner condition could come into play with a patient is if a patient requests that you send their EHI to a third-party application, but your EHR hasn't developed the certified application programming interface or API technology needed to connect to that third-party application. Because the patient request is covered under the patient right of access, you can't charge the patient for this. But if you're technologically unable to fulfill the request, again, you can turn to the manner condition. Once you start with the manner condition, you have to go through a list of alternatives. So basically, you have to work with the requester to find a way that is workable for you and agreeable to them. And you have to do it in the specific order. If a requester then requests that you use ONC certified technology, like an EHR or any certified health IT that the requester specifies, you have to do that unless you are, again, technologically unable to do so. If you can't do it, then you move to number 2, using a different requester specified transport, content and transport standards, either published by the federal government or ANSI, the American National Standards Institute. So this could include things like if your EHR isn't yet on FHIR version 4, using instead FHIR version 2 or HL7 to transmit the content of the request. If you're still technically unable to do this, and the requester has requested those 2, then you can move on to number 3, which is using an alternative machine-readable format agreed to by the requester, inclusive of means to interpret the EHI. What this means is this does not include a PDF because that is not machine readable, that's only human readable. This is things like a CSV file. The most important part of this condition is that you can only progress to the next step if it's requested, if you cannot technically fulfill the manner requested. Now, what if you still can't fulfill the request? This is where the infeasibility exception comes in. The infeasibility exception states that it's not information blocking if an actor doesn't fulfill a request to access, exchange, or use EHI due to the infeasibility of the request, provided, again, certain conditions are met. The conditions are listed here on the right-hand side of your screen. You must meet one of the conditions here, uncontrollable events, such as a public health emergency that prevents you from actually going into the office or has wiped out your ability to transmit because all of the internet and systems are down. Like, for instance, COVID, where you couldn't go into the office for a while, a lot of practices shut down. You weren't really able to fulfill a request at the beginning until we got into the swing of things. Or let's say there was a hurricane and the internet was down. That would be under uncontrollable events. Then there's data segmentation. So let's say you are unable to release all of the information contained in a file, either due to privacy reasons or patient harm, and we'll get into those exceptions in a minute. But you're also unable to segment the data because your EHR hasn't had that functionality built in yet. So it's either all or nothing. That is what that portion of this condition means. That would make it infeasible for you. And then finally, infeasibility under the circumstances. This is where you end up if you go through the content and manner condition and you're still unable to fulfill the request. The most important thing here is that you must have a contemporaneous written record of the request and the reason that you couldn't fulfill it. And it must be implemented in a non-discriminatory manner. What does this mean? The contemporaneous documentation should include things such as the type of EHI and the purposes for which the EHI may be needed, and factors that factor in to the infeasibility in complying with the request, such as the cost to you of complying with the request in the manner requested, the financial and technical resources you have available, and of course, your practice's non-discriminatory application of these factors. In other words, you can't only comply with requests from those with whom you have a business relationship. That would be both anti-competitive behavior and information blocking. Finally, it's important to document why you were unable to provide access, exchange, or use of EHI consistent with the content and manner exception. As noted on the last slide, you must provide a written response to the requester within 10 business days of receipt of the request, with the reasons why the request was infeasible. So what if the request isn't infeasible, but you're worried about how it will impact the patient? That goes into our next exception, the preventing harm exception. This exception states that it's not information blocking to engage in practices that are reasonable and necessary to prevent harm to a patient or another person, provided again that certain conditions are met. These conditions are on the right-hand side of your screen. The first is that you must hold a reasonable belief that the practice will substantially reduce a risk of harm. Next, your practice must be no broader than necessary. Then also, your practice must satisfy at least one condition from each of the following categories: type of risk, type of harm, and implementation basis. We'll go through type of risk and harm on the next couple of slides. Implementation basis refers to having a written organizational policy or determination specific to the facts and circumstances. If the latter, concurrent documentation is required and must be based on expertise relevant to the determination. Finally, the practice must satisfy the condition of allowing a patient to review an individualized determination of risk of harm. So the condition of type of risk is presented here. There are two possible branches for this condition. One is risk determined by a licensed healthcare professional. To meet this, an individualized assessment must be made via the exercise of professional judgment, and the person making the assessment must have a current or prior clinician-patient relationship with the relevant patient required. The other type of risk is risk arising from misidentified, mismatched, corrupt, or erroneous data. This one's pretty self-explanatory and doesn't require a licensed healthcare professional determination. So, how are these applied in specific circumstances? That brings us to the type of harm condition. There are two types of harm addressed: substantial harm, defined in the Federal Register as substantial physical, emotional, or psychological harm, and harm to life or physical safety. These are applied in different circumstances. Substantial harm is allowed under two circumstances. The first is request by the patient's personal representative under HIPAA or other legal representative for the patient's EHI. So the substantial harm must be either to the patient or another person, and the licensed healthcare professional must determine the risk. In this example, it might be that the personal representative is suspected of elder abuse to your patient or domestic violence, in which case having notes released to the personal representative that state this would cause substantial harm to the patient. And it would also increase barriers to care, as you're unlikely to see the patient again, leaving them one less safe space and one less venue for care. The next is request by a patient or patient's representative to EHI that references another person aside from the patient. The substantial harm must be to the person referenced, and that person can't be a healthcare provider. A licensed healthcare professional, again, must determine this risk. So in this case, let's say you reference a family member because you're noting that they show certain similarities, but referencing the family member may disclose a previously undisclosed diagnosis of, say, HIV, which under your professional judgment might cause substantial physical, emotional, or psychological harm. In that case, it is okay to not release that specific note. But again, you have to release as much as you can. That's where the data segmentation condition in the Infeasibility exception comes into play. Hopefully you're able to segment the data and provide the data that doesn't cause harm, but if you're not, then look again to the Infeasibility exception. The other type of harm, harm to life or physical safety, is the one that will probably be most often applied. This is because this refers to a request by a patient for their own EHI, whether it's for them or for them to send to a third-party application. The harm must be to the life or physical safety of the patient or another person, and the risk of harm must be by a licensed healthcare professional or must arise from a data integrity issue. In this case, let's say you have a patient that you suspect of malingering, and you have charted very extensively in a note the instances in which they have gone into the hospital and gotten abdominal surgery and nothing was found. In this case, letting the patient know that will probably cause them to go to another healthcare provider that may not suspect malingering and could cause additional unnecessary surgeries rather than causing a more thorough examination of the patient's symptoms prior to heading to surgery. That's life and physical safety of the patient. Finally, any legally permitted access, exchange, or use that's not covered. This is a catch-all. If it's not covered by these conditions, these exceptions here, then it still must be harm to life or physical safety. ONC included this in case they missed something. And again, this risk of harm must come from a licensed healthcare professional or arise from a data integrity issue. That brings us to the last condition of the preventing harm exception, implementation basis. There are two ways to implement a preventing harm exception. One is through written organizational policy, and the other is a determination specific to facts and circumstances. For written organizational policy, this could be something along the lines of not releasing notes to a personal representative that's suspected of abuse. That way you don't have to have a lot of concurrent documentation stating why you didn't release the record. It's organizational policy. However, you can't have an organizational policy to, say, delay test results to a patient until the provider has had a chance to discuss them with a patient. You can, however, make this judgment on a case-by-case basis. That brings us to a determination specific to the facts and circumstances. This could be, for an example, knowing how significant a test result would be to a patient and determining that there is a real risk to life or physical harm in releasing the results. That would have to be based on your current patient-provider relationship. Then you could delay the release of the test result for that specific patient until you have had a chance to discuss it with the patient. If you go this route, you will need pretty substantial concurrent documentation, and it must be based on your expertise. HIPAA documentation that is used for preventing harm is often sufficient. So that's it for the preventing harm exception, and next up is the privacy exception. This exception states that it's not information blocking for you to not fulfill a request to access, exchange, or use EHI in order to protect an individual's privacy, provided, again, that certain conditions are met. The conditions are found on the right-hand side of your screen, and there are 4 possible ways to claim this exception. First is preconditions not satisfied. So if you're required by state or federal law to satisfy a precondition, such as patient consent or authorization, prior to providing access, exchange, or use, you can choose not to provide that access, exchange, or use as long as the precondition hasn't been satisfied and you make a reasonable effort to satisfy the condition. Next is health IT developer of certified IT not covered by HIPAA. This one doesn't really apply to providers unless you're also a health IT developer. Basically, this is allowing health IT developers who are not covered by HIPAA to follow privacy practices that are concurrent with HIPAA or similar to it without being accused of information blocking. Third is the denial of an individual's request for their EHI consistent with 45 CFR 164.524A1 and 2. So that's a lot, but basically this covers the reviewable and non-reviewable grounds under the HIPAA privacy rule. For instance, 164.524A1 includes psychotherapy notes and information compiled in reasonable anticipation of and use for a civil, criminal, or administrative action proceeding. 164.524A2 covers the unreviewable grounds under HIPAA, including what I just stated, and also an inmate's request to obtain a copy of PHI, an individual's access to PHI created or obtained in the course of research that includes treatment. Of course, a patient must have been informed of this at the time of signing up for the trial. An individual's access to PHI contained in records subject to permitted denials under the HIPAA privacy rule, and an individual's access to PHI obtained from someone other than a healthcare provider under a promise of confidentiality. Last is respecting an individual's request not to share information. This aligns with HIPAA. If a patient requests that you not provide the access, exchange, or use of EHI without first contacting them and getting their okay, you're allowed to not provide it, as long as you don't give any improper encouragement or inducement for the patient to make that decision. This goes along with what we discussed under the examples of information blocking, with you potentially being at risk of information blocking if you lead a patient to not allow their data to go to a third-party app. So as long as you don't provide improper inducement, you are allowed to give a uniform statement about apps not covered by HIPAA and not being covered by HIPAA, as long as it's fact-based, accurate, and up-to-date. So we recommend something very general, just so that your patient knows that the data that they're releasing isn't going to HIPAA-covered entity, but not discouraging the patient from using whatever app allows them to be more involved in their care. So that's it for the privacy exception. Just like the other exceptions, we recommend that you document and have a policy in place at the very beginning. Next up is the security exception. This is the last exception that we're going over in today's webinar. This exception states that it's not information blocking for you to interfere with the access, exchange, or use of EHI in order to protect the security of EHI, provided, yet again, that certain conditions are met. The conditions on the right-hand side of your screen state that the practice must be directly related to safeguarding the confidentiality, integrity, and availability of EHI, tailored to specific security risks, and implemented in a consistent and non-discriminatory manner. The practice must either implement a qualifying organizational security policy or implement a qualifying security determination. This just means that it's either organizational policy or done on a case-by-case basis, much like the previous exceptions we've discussed. Importantly, the security risk must be to your own practice's EHI storage, your actual network. You are not allowed, for instance, to block information flow to an app simply because you don't believe it has sufficient security to protect the data it holds. You can only block it if connecting to the app would pose a security risk to your practice. If you implement an organizational security policy, the policy must, 1, be in writing, 2, have been prepared on the basis of and be directly responsive to security risks identified and assessed by or on behalf of you, for example, in a HIPAA security risk analysis. 3rd, it must align with one or more applicable consensus-based standards, such as the NIST cybersecurity framework or best practice guidance. And finally, it must provide objective timeframes and other parameters for identifying, responding to, and addressing security incidents. In the preamble of this rule, ONC recommends that the policy explicitly reference applicable consensus-based standards or best practice guidance. We really recommend looking at the NIST incident response procedure as an example of an acceptable source for the development of a security incident response plan. If the security practice does not implement an organizational security policy, you must have made a determination in each case based on the particular facts and circumstances that 1, the practice is necessary to mitigate the security risk to your EHI, and 2, there are no reasonable and appropriate alternatives to the practice that address the security risk and that are less likely to interfere with, prevent, or materially discourage the access, exchange, or use of EHI. This condition, which allows a case-by-case analysis, will be helpful where you need to protect EHI against an unexpected threat that's not addressed by your organizational security policy. We do recommend having an organizational security policy as addressed on the previous slide, but if you have to use a case-based determination, make sure that you have appropriate concurrent documentation to support your blocking of the information flow in case you need it for an investigation. So that's it for our background and exceptions, and we get to move on to the next steps, how you can prepare. To prepare your practice to succeed, we recommend designating an information blocking leader in your practice. If you're listening to this webinar, that might be you, but it could also be a health IT staff person or administrative staff. 2, review existing policies and procedures. You should revise these as necessary to make sure that they don't conflict with information blocking regulations. Also ensure that you have policies related to the exceptions documented in writing. 3, establish a process to apply and document exceptions. This is very important. As I've stated in the exception slides, concurrent documentation is important anytime an exception is applied. 4, train your staff. You may know about the information blocking regulations and exceptions, but your staff might not, It's important that you let them know what's going on so that they can comply with the regulations. Also important, inform your clinicians that their clinical notes will be available for patients to read. While we don't anticipate major documentation changes, things such as using SOB for shortness of breath could be pretty easily misconstrued. In addition, statements like patient claims are very common in medical documentation, but they're easily misunderstood by patients as meaning that you don't believe their chief complaints. We recommend changing that to something like patient states. It's a short and easy change that will reduce confusion moving forward. Finally, if you're going to continue to use medical abbreviations, we recommend providing your patients with a glossary of the most commonly used medical abbreviations by your practice. This will reduce confusion and questions moving forward. Next, evaluate all data use agreements and business associate agreements that could intersect with information blocking. This is a very important step. If any of these agreements contain provisions that interfere with information flow, that's information blocking. So make sure that this is a step that you do. Next, ensure that your MPPES profiles in the MPI database are updated with your direct address and, if possible, your FHIR endpoints. You should be able to get these from your EHR vendor, and updating these profiles is actually required under the CMS Interoperability rule. We'll post a link to a blog in our show notes that goes over how to do this. It should only take you a couple of minutes. Finally, connect with your health IT vendors to get updates on their progress toward meeting the information blocking regulations and to identify solutions for your practice's needs. And last but not least, if you have any questions or need additional assistance, we're here to help. Marston Advisors likes doing things that you hate dealing with so that you can focus on your practice and patient care. A link to our website is in the show notes, and we look forward to hearing from you and helping you comply with these very complex information blocking regulations.